Pillai.
Good evening, everyone. Welcome to iFocus Online, Lecture 183 and Retina Session 35. Today we have with us Dr. Rajiv Raman, sir, and he'll be talking on diabetic retinopathy screening strategies. I request Dr. Ajit Babu, sir, to please introduce Dr. Rajiv Raman, sir.
Good evening, everyone. Welcome to the retina session. This is mainly regarding the epidemiological aspects, and Rajiv is one of the best for this area, and I known him for a very long time, and he has been with Nethralaya for a very long time. In between a few years, he was out of Nethralaya and come back because of his lot of academic enthusiasm. And he's the starter of SN Dreams project, which many of the people who are known in retina, they know very well about SN Dreams, and then Ornet India also. And his particular interest is on the tele-ophthalmology, and he has done a lot of good work, and a lot of publications are there regarding diabetic retinopathy and tele-ophthalmology and screening aspects of diabetic retinopathy. And he is one of the leading members of the AWS, mainly the program for diabetic retinopathy screening across the country. And he is a prolific with a lot of publications, and he's been on the journal editorial boards for IJO particularly, but there are several other journals he's been on the board. And he's very learned medical retina personality, I should say. Though he does surgeries, but his medical retina is very, very strong. And today he will be talking about the diabetic retinopathy screening programs. Dr. Rajiv, it is over to you. Your microphone need to be activated, and then.
Thank you, sir. Thank you for the kind words. And I'll just share my slides.
Yeah, please.
Slides are visible?
Yes, sir.
Yeah, they are visible. Full screen, yes.
Yeah.
Okay.
Thanks, Santosh, for asking me to be a part of this important iFocus meeting, a very popular forum. Many of the postgraduates, they love to be part of it, and it's a great learning platform. Dr. Shobha could not be there. She was the person who was supposed to talk, but I'll try to cover some of the important aspects of diabetic retinopathy screening, how we can translate it to our clinical practice. So International Diabetes Federation, every year they come out with some statistics. They tell that how common is diabetes, and truly diabetes is an epidemic. It's not true only for India, but a global epidemic. 2021 globally, about 1 in 10 people have diabetes, nearly 537 million people. And they estimated this to become 1 in 9 in 2030 and 1 in 8 in 2045, staggering numbers of people who have diabetes. And the sad part is that 1 in 2, they don't know that they have diabetes. So what we are talking about is only people who know that they have diabetes. So there is a big burden of undiagnosed diabetes in the community. And this is the list of top 10 countries who have maximum number of people with diabetes. And if you look at China, India, and US, nearly half of all people with diabetes, they just live in these 3 countries. That's reason it becomes very important, especially for our country. And there is a specific phenotype which has been described called as Asian Indian diabetes phenotype. So people with diabetes in India are a bit different from the diabetes which is in the other countries. So we have a low BMI, we have more abdominal fat, we have more visceral fat, there is more central obesity, we have more inflammatory markers, we have insulin resistance, we have high rate of type 2 young onset. Usually young onset is type 1, but we have many people with type 2 who are young onset, childhood obesity, gestational diabetes, and even the viral causes high rate of cancer, especially liver cancer. So all these are the typical phenotype which is seen in India and very well described as Asian Indian diabetes phenotype. Recently, Dr. Mohan has also described some different subgroups of diabetes in India, which give them a propensity for microvascular complications. So he has described, based on BMI and C-peptide, we have what is called as severe insulin deficient diabetes. These are the people who are very prone for diabetic retinopathy. They have a low BMI, so they are not the obese diabetics. They have, so in clinic also many times we see that people with PDR, unlike in West where they say that body weight is important risk factor, we have lean diabetics having diabetic retinopathy, and they have low C-peptide. So these are the group of people who are more prone for retinopathy. The another variety which he described was insulin resistant obese diabetes, again depending on the C-peptides, BMI and waist circumference. And these are the people who are more prone for diabetic kidney disease. Then we have a combined group, which is combined insulin resistant and deficient diabetes, and they are prone both for retinopathy and diabetic kidney disease. And fortunately, the most common type of diabetes in India is called as mild age-related diabetes, which is the most frequent cluster, and they are the ones who have very less chances of microvascular complications. So that's the type of diabetes which has been described more recently, which we should be aware about, that there is some subclass of diabetes more prone for retinopathy. If we look at the largest data on prevalence of diabetes across 15 states in India, this was an INDIAB study, the INDIAB ICMR supported study, where they found that it's nearly we have 77 million people with diabetes. And this study also demonstrated that there is a rural-urban difference. There is difference as far as low socioeconomic and high socioeconomic status is concerned. And prevalence seems to vary from 5 to 16%. And there are certain areas like Chandigarh, Tamil Nadu, Punjab and Kerala, where 1 in 10 have diabetes. It's the areas of high prevalence. Though we see that there are regional variations in prevalence of diabetes across the country, all states in India should implement a population-based screening program for its complication, including diabetic retinopathy. The Lancet paper also very elegantly described that there is what is called as a socioeconomic diabetes epidemiology transition. So what is actually happening that more developed states in the urban area, we have more diabetes in lower socioeconomic status, whereas in less developed states in urban area, it is the higher socioeconomic status people who are having more diabetes. But in rural areas, both whether it is developed or less developed, there is more diabetes in higher socioeconomic status. So this transition is seen in India over last couple of years. However, once a person is diabetic, it doesn't see whether he is rich or poor, low socioeconomic or high socioeconomic. The risk of having diabetic retinopathy seems to be same. And the prevalence of retinopathy in urban area, nearly 1 in 5 has retinopathy as compared to rural, where it is 1 in 10. The prevalence of retinopathy may be low in the rural areas, but the prevalence of sight-threatening retinopathy, which includes severe non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and diabetic macular edema, seems to be same across urban and rural population. Also, the fact that people who are newly diagnosed, the strongest risk factor for diabetic retinopathy is duration of diabetes. However, nearly 6% of people who were diagnosed to have diabetes, that time they have retinopathy. That means they had undiagnosed diabetes for a longer time. Rural area, it's nearly 3%. So there are some rural-urban differences as far as retinopathy is concerned in our country. As an ophthalmologist, it is essential to ensure that we do a timely detection of sight-threatening retinopathy. We have some screening programs in place. However, we should also have protocols in place for a prompt treatment. Screening alone is insufficient. You screen people and you don't have the facility to treat, you cannot complete the loop. So you should have protocols in place for a prompt treatment. Equally important is awareness, which next few slides I'll share. That's a big thing, that people are not aware about the eye condition. And then we need to also refer to the physician for a control of the risk factor and associated complications of diabetes. So that's the reason screening is important. If you look at this is a study which looked into knowledge, attitude, and practice. Though people knew, 50% knew something about diabetes, a third knew about retinopathy. Those who knew were also aware that they need a regular eye exam. But if you look at the practice, only a third of them actually visited an eye doctor on a regular basis. So there is a big gap, though one is the knowledge and awareness is poor. Practice, even those people who had knowledge, the practice is poor. So definitely there is a need for a systemic diabetic retinopathy screening program. And this was again a work which was done by PHFI, Public Health Foundation of India. And they looked into various eye units, eye hospitals, and they found that 45% of the patients with retinopathy who are attending eye hospitals have already lost vision. So we know that when you lose vision, it's usually macular edema or a proliferative stage leading to complication. That means they never had any eye examination has been done for them. And this shows that we are doing really too little, and that too we are doing too late. So whom we should screen for retinopathy? So we need to identify people with diabetes for diabetic retinopathy screening. And who are eligible people? All people with diabetes, known diabetes, who are on treatment, or if a single record of a random blood sugar is more than 200, or HbA1c more than 6.5, or a gestational diabetes when first notified to a medical personnel. So these are the group of people you want to screen for diabetic retinopathy. From where we get these patients? So either they are the patients who are visiting ophthalmologists for a cataract surgery or any other surgical procedure, what we call as an opportunistic screening, or a community screening which is conducted by a physician or an ophthalmologist through a non-communicable disease register, which have been maintained by Government of India in various PHCs, pharmacy where people come to take their medications for diabetes. Again, that's a place where you can identify people with diabetes, physicians, because they are the first person to see the people with diabetes, or labs where they go for a lab checkup. So you can identify people who need screening at multiple of these places. What are the screening intervals when the people with diabetes should have a checkup? This is the finding from our population-based study. Dr. Ajit was mentioning the SN Dreams follow-up study, 4 years. And we found that in 4 years, the incidence of retinopathy is nearly 9%. It's not too great, too high. So important is people who already have some form of retinopathy, you see they have more chances of progression to sight-threatening retinopathy. Nearly a third of them progress in 4 years. So these are the people who need more frequent follow-ups, and people with no DR need less follow-up. And what less? So what American Academy and what various guidelines suggest us that if a person doesn't have retinopathy, he can have yearly checkup. And if there are various stages of retinopathy, till moderate, if it is not a sight-threatening retinopathy, he can come 6 monthly. And if it is a severe NPDR, then the situation, depending on what treatment and what is the eye condition, the follow-up will change. The problem is we have so many people with no retinopathy, that is only diabetes. Can all of them have yearly checkup? Can we have more than annual follow-up? Meaning that can we see them 2 yearly once? And there are some attempts which are done. This is a model called as retina risk algorithm. They use various risk factors to predict what would be the progression, risk of progression to a sight-threatening retinopathy. And this algorithm has been validated across various populations. So this was based on Wisconsin data, this algorithm has been prepared, and they tried validating it in various populations. And we thought that let's look into, can we use this algorithm in Indian population? And we use the SN Dreams data set to try to see how accurate it is. It was not that great. The AUC was 0.79. However, we tweaked the model a little bit more. We added some more parameters to it. And now it is nearly 0.84, better than the original form. But this can be one way of progress. So if by this algorithm, we find that the risk of retinopathy is less, it also gives the approximate time for follow-up. So it gives a time like it can be seen after 2 years too, depending on blood pressure, the BMI, the duration of diabetes, HbA1c. These are the parameters it uses, and a retina status, whether already DR is present or not. People have also tried using deep learning approaches to find out, can we predict the progression of retinopathy? And this group from Google have been really very high accuracies, looking at only the risk factors. It can predict whether a person, what is the risk of developing retinopathy. We all are very keen to forecast future, and this is one way we can probably think of whether the follow-ups can be more frequent or less frequent. Coming to the screening models, so there are many community-based models which can be done for screening retinopathy. One simplest thing, if you don't have any other equipment, take your indirect and go for an outreach program, diabetic retinopathy screening camps, where you call people who have only diabetes, invite them for this camp and do a dilated eye examination. This is one way. It's not a bad method. We use this in one of our Lions Club program, very successful, where we screen nearly about 50,000 people in South India. You can do a opportunistic retinopathy screening, as I told you, in a diabetes clinic or a general physician clinic, pharmacy, or medical lab, where you can put a camera, a non-mydriatic camera, a trained person can take the images, and ophthalmologist or a person grader can grade these images. Or what Arvind, Nethralaya, MV Diabetes, and many of the institutions have been using is a mobile van approach, where you have these equipments in a van and you do a screening at their doorsteps. Or it can be at the vision center. So primary eye care, either even the physician, though a direct ophthalmoscopy is not a great method of diagnosing, the sensitivity specificity is poor. However, if the physician doesn't have any gadget, at least a dilated direct ophthalmoscopy is a pretty simple technique to try to pick up these patients who have retinopathy. Or screening by a fundus camera at the various PHCs. So these are the various methods by which screening can be done. Who should take a photograph? This is an article in Indian Journal of Ophthalmology, where we had published the AIOS and VRSI guidelines for diabetic retinopathy screening. And it gives the various competence levels, and anybody who has at least level 1 of competency can be involved in capturing retinal images. Which fundus camera to use? And last 5-6 years, the retinal cameras, the non-mydriatic cameras have really become affordable. It is not in the range of 2-digit lakhs. It is now in very less cost you can get. And there are a variety of that. And AIOS recommends that retinopathy retinal imaging equipment should have a minimum resolution of 6 megapixel or 30 pixels per retinal degree. Whether to use a handheld or a tabletop, both have got its advantage. Handheld has the advantage of carrying it to the field, doing a house-to-house screening. The disadvantage is it needs a little training, and sometimes the image quality, the movements of the hand can cause a little poor quality. More stable is a tabletop model. However, it limits the portability of this instrument. There are many of these mobile phone attachment cameras versus a standard camera. Definitely, as far as quality of image is concerned, the standard camera quality is better, though nowadays with the high resolution images, mobile phones, these fundus photographs are also not bad. However, if you compare mobile versus standard camera quality is definitely better. How many fields of retinal images are enough for doing a retinopathy screening? The American Academy of Ophthalmology guidelines suggest that a single field, which is focused on the fovea, that is fovea-centered single field, in which the whole of the disc also comes 45 degree, is enough to do a basic diabetic retinopathy screening. However, we know that the lesions may not be only in this field. The more fields you include, the screening accuracy becomes a bit more. So there are only thing is that makes the screening time becomes more, and sometimes acquiring also needs a little more skill. That means a single 45 degree posterior pole image centered at fovea should be good enough to do a diabetic retinopathy screening. However, nowadays there are another thought coming on the wide field fundus photography for retinopathy screening, because we have started understanding that retinopathy lesions are not classically in these 7 fields which have been described by ETDRS. Many times you see these lesions beyond that, what we call as predominantly peripheral lesions called as PPL. And this is a work which has been done by a couple of institutes in India. And we did find that nearly 10% of peripheral DR changes, they suggest a more severe scale. That means this patient, if you look at only the 7 fields, you will label it probably as a mild to moderate NPDR. The moment you see the periphery, it becomes PDR. So 10% of the peripheral changes becomes a more severe scale. A third of these ultra-wide field images show predominantly peripheral lesion distribution. And we also found that the temporal quadrant has maximum distribution of PPL. And Dr. Paul Alelo group also very nicely showed that these patients who have this PPL, their chance of progression is nearly 4 times more. So we cannot afford to miss these patients. That's the reason now the thought is coming that whether this single field is enough or not, but for community screening, definitely yes. If resources are there, ideal would be a wide field fundus camera screening for all. This is one of our recent work where we tried comparing 2 wide field cameras. Again, there is no commercial interest, but one of the wide field is really more periphery is seen. The second one has got a higher resolution. And what we found that in retinopathy, though we talk about these peripheral lesions, which are seen in a third of the cases, more important is identifying these posterior lesions more clearly. So you need a high resolution rather than a more view. So this was one of the study which got recently published. Whether to dilate or not to dilate for doing a retinopathy screening, when we use a non-Mederatic camera and take the images, a third of them will become ungradable. You cannot grade these images. And this was one of our study where we also found that this is in people mainly who are aged, more than 60 years, or vision is less, indirect surrogate measure of a cataract. So in these patients, if we dilate and take the images, the quality of image, this 30% becomes only 5%. So when we can do, so either you can do a targeted mydriasis, meaning that irrespective, anybody more than 60 years or less vision, you dilate and take the images, or you can do a staged mydriasis. You take a non-mydriatic image, and if the image is ungradable, you dilate and then take the image. But definitely keep in mind the shallow angles, do a von Herrick test before you plan for dilating these patients for diabetic retinopathy screening. Why there is nowadays another concept of using artificial intelligence, and next couple of slides I'll be sharing why AI is something which is in there for diabetic retinopathy screening. We have many diabetics, less ophthalmologists, and if you consider that each of them have to be screened yearly, that means a lot of work for ophthalmologists, physically not possible. The second good thing about retinopathy is that we have a very good established grading system, which is not there for many diseases. And it has been for ages, we know these stages of retinopathy. So training an algorithm to identify these stages is a little simpler task. Another important thing is there are a lot of inconsistencies in grading. So these are actually 30 experienced board certified ophthalmologists who were grading some of our images. And these ophthalmologists, if you see these images, there's so much disagreement or inconsistency among them. That again shows that a way by which we can have a uniform way of grading. And what is more worried is the yellow ones, where a sight-threatening retinopathy has been called as moderate NPDR. So definitely there is a need for a more unified approach. But we are better actually. This is the same graph for glaucoma. Glaucoma, it is worse because definitions of glaucoma itself is a query. So retinopathy is better than that. And there are many algorithms which have been made till now. And what do the DR screening guidelines say about using AI for retinopathy screening? And in 2020, the American Diabetic Association, they included diabetic retinopathy, the AI systems for detecting more than mild DR and DME. They suggested that you can use any of these the algorithms which have been approved by FDA as an alternative to a traditional screening approach. They also said that these should be documented and the results should be referred to a healthcare professional. They also went ahead telling that when not to use AI for retinopathy screening, patients who already have retinopathy, you should not use an AI, they should have an in-person evaluation. Those who are already on treatment, or when there are symptoms of visual impairment, they should definitely be seeing an ophthalmologist rather than just having an AI to diagnose retinopathy. Even in the All India AIOS guideline, we suggested, because we don't have any legal framework for AI use in retinopathy screening, it's empirical that the ophthalmologist to grade all those who have been identified as referable by the AI algorithm, and nearly 10% of the ones which have been identified as normals should again be seen by an ophthalmologist grading. Are these AI algorithms accurate? So this was actually one of the first paper which we had published in JAMA with the help collaboration with Google, where we tried validating and we developed this deep learning algorithm for diabetic retinopathy screening. And after that, there have been a chain, I would say, so every week you put in PubMed, there'll be 1 or 2 papers on retinopathy screening using deep learning. The good thing is accuracies of most of them seem to be reasonably good. So if suppose you are planning to get an AI algorithm, now many of them are commercially available, and you want to plan what algorithm I should use in my clinic, you need to look into multiple things, because these algorithms, you need to know how they were developed, what was the training set which was used for creating these algorithms, how was the ground truth ascertained, because for AI to learn or deep learning algorithm to be made, you need to give ground truth, and how these ground truths were made. You can have multiple methods, a majority ground truth, like what we did in this JAMA paper. We had 30 board certified ophthalmologists grading all the images, nearly 2 lakh images. And we took the majority grade as the final grade. Or you can have the primary, secondary grader and education by a third person. So there are multiple ways. And these methods are very sound methods. If a single person telling the ground truth, it may not be a very great algorithm, because we have seen that there is so much variation among people to identify retinopathy. And if you feed in a wrong diagnosis, the AI will learn wrong. Whether this algorithm was trained using a mydriatic image or a non-mydriatic image, very recently we have published a paper like the Zeiss AI model, which comes with their fundus camera, is actually developed on a mydriatic image. They are using what is called a Selena, which is a AI model developed by Seri Group, and the camera is a non-Medretic camera, so that's a problem. Or whether the algorithm was trained on a single field versus multiple fields. So you need to look into what, and ultimately you need to decide, select the algorithm depending on the circumstances of an intended screening. So if you're planning to use multiple fields, you're planning to use a Medretic or a non-Medretic, based on all these things, you select an algorithm. Is the performance of these AI algorithm dependent on camera? Again, this is one of our work where we tried comparing the gradable and non-gradable images and seeing the human grader versus AI grading across 9 different fundus cameras. And what we found that for a gradable image, the performance of AI algorithm seems to be similar across all the cameras. There is not much difference, but a non-gradable image, definitely there are problems. So now people are working on various ways of improving the efficiency of AI algorithms in retinopathy screening. And this actually 2 days back, this is one of our paper which came in Ophthalmology Retina, where we did a little different thing. We took the retinal images and we labeled it with OCT data. So if you see the second image, clinically you don't see macular edema, but if you see the OCT, there is central involving diabetic macular edema. So these are the type of images where sometimes just by retinal image, you cannot say that they have a DME. And we took the retinal images, took the labels from OCT and trained a model so that just by fundus photograph, can we predict whether they have a center involving or a non-center involving DME. And with a very good accuracy, nearly 0.89, we could do this. So these are the possibilities where our screening will really change. We don't need a OCT. If we have this AI algorithm and a retinal photograph, we can probably tell whether there is a center involving DME or not. This is another of our work where we tried looking at, can we improve the gradability of the retinal images, handheld non-Medretic cameras, and we tried training it for ungradable versus gradable. Why this is important? Because if a photographer takes the image and the AI tells it that this is non-gradable, he can retake the image. Or what I was telling, the sequential dilatation, he can do that and take the images. So definitely it has got application as far as diabetic retinopathy screening is concerned. How we can implement these AI algorithms? So people are using it 2 modes, like you can use it like what Aravind Eye Hospital has been using. People who don't have any knowledge on diabetic retinopathy, they just upload the image, AI gives the diagnosis and the referral criteria. How we are using at Nethralaya is by people who are anterior segment specialists who have knowledge, but they're not involved directly in retinopathy screening. And these patients, we upload the image, the ophthalmologist has a chance to grade the image. The AI also grades, and we shows this grading of AI to the ophthalmologist, and he has a chance to relook at his diagnosis and augment his grading if required. But finally, the grading of the ophthalmologist is the final grade. This is a small video which shows that how we have integrated it with our EMR. So the patient visits the optometrist takes a consent for using the AI grading, screening. He uploads the images. And once these images are uploaded, he also writes whether they were dilated or whether there is presence of cataract or not. Now he goes to the consultant. The consultant has a chance to grade the image, the grade of retinopathy and the grade of DME. And then he shows AI results. And he has, if it is different, he can again relook and change if needed. So we have been using successfully in our OPD for last probably about 8 to 9 months. And even in real time, the performance seems to be same what we had published in JAMA, a very high specificity and sensitivity. We also tried using another AI algorithm which can detect both the suspicious glaucomatous disc and diabetic retinopathy. And we thought that can we reduce the referrals by using this? So this is so in the glaucoma clinic, we use the ground truth of the retina specialist. And in the retina clinic, we took the ground truth of the glaucoma specialist. So very successfully, it could detect the diabetic retinopathy. That means we can really reduce the referrals in these two clinics. And lastly, what is the acceptance of AI among ophthalmologists? Again, this is a multi-centric, nearly more than 1,000 ophthalmologists from 70 countries. People are trying to now accept it, especially in this COVID pandemic. And there are certain barriers. Medical liability errors is a big thing. The legal requirements are not clear. And definitely, one of the enabler was it improves the access to screening. So to conclude, a good initial diagnosis by a good screening and appropriate referral, and also the systemic management and a good systemic control, we can offer a best care for diabetic retinopathy. Thank you once again. I'll be happy to take any questions. This is my diabetic retinopathy team and my retina team at Nethralaya. Dr. Ajit.
Sir, your audio is mute. Yes, sir.
Yeah, a very good presentation. Actually, a lot of data is there, and now we will look towards the hot seats.
Yes.
Whether they could catch everything or not. Number one. Number two, whether they have more doubts.
Yeah, Dr. Rajneesh wanted to know in pregnancy, what is the criteria to screen? So if a person already is a known diabetic, definitely actually before, like at the time of conception, that time itself screening should be done. And thereafter each trimester you should do it. However, if person develops gestational diabetes, then usually it's not required, because it's not like they will have, but once it is diagnosed, one screening should be done that time for retinopathy screening.
Yeah, well, that is the difference between already diagnosed diabetic getting having a pregnancy or gestational diabetes.
However, people who have gestational diabetes, they tend to become diabetic very often.
Very often, but it will take 5 to 10 years from the time of diagnosis.
Yes. Another question Rajneesh has, that when to laser in pregnancy. Yeah, so see, there are two things. You do treatment for retinopathy for a DME, and you do treatment for proliferative retinopathy. So if suppose, let's first talk about DME. So DME usually in the, if it is in the late trimester, last trimester, just leave it. After pregnancy, the macular edema will go away after the delivery. Yeah. However, if it is in the early pregnancy, you don't want to give anti-VEGFs if it's a central involving. You can still do laser, which is relatively safe. Steroid, I am a bit concerned because they are young. You don't want clear lens. But early pregnancy, you treat it. Late pregnancy, DME, you don't treat. PDR, anytime you see PDR, definitely do laser. There's no contraindication.
Yeah, you can do LAO. Is it Rajneesh who has asked? Yeah, you can do LAO in late pregnancy as well, because this patient sitting on the slit lamp and get slit lamp laser is a little bit difficult. As Rajiv told, early pregnancy, it is very easy. As normal patients, you can treat them very well with laser for PDR. For diabetic macular edema, you need to see the grade of diabetic macular edema, whether you can easily wait and watch for 2-3 months. There is no urgency in diabetic macular edema treatment.
Correct.
So you can take accordingly, according to the stage of the pregnancy, and then treat accordingly.
Yeah, Dr. Soni wanted to know low BMI patients with insulin deficient diabetes. How does it cause more risk of retinopathy? Again, this study didn't look into the mechanisms, but they described the 4 epidemiological patterns. So this was a large population. And the good thing is the same type of study was also done in Sweden. And they also found a similar. So that means this type of correlation does exist that you have people with low BMI, insulin deficient diabetes, they have more risk of DR. How feasible are these new screening methods with respect to cost effectiveness in a resource poor country like India? That's the reason in India we need to keep a variety of these options in mind. Fundus camera, though, as I was telling, the cost of cameras have really gone down. At one time, it used to be 10 to 15 lakhs. Now 1 to 2 lakh, 3 lakhs you can get. But that is something you need to propagate more, because their sensitivity, specificity of using cameras and photography for screening is much better than using a direct or an indirect ophthalmoscopy. So, and second is, you don't have so many people doing direct and indirect ophthalmoscopy. So it has to come to a hand of a physician. Using AI, again, many of these companies are coming up with the cameras inbuilt with AI. So you really don't have to invest more for that. So that's something which is very feasible. Yeah.
And Rajiv, one thing you need to highlight in AI is the number of persons you are screening. Then the specificity and sensitivity will increase, keep on increasing.
Yes, it's a learning, so it learns by itself. Yes,
that is another thing which we need to highlight. And the quality of fundus photographs gradability is very, very essential. Whether we are taking at the time of taking the fundus photograph itself, if it is not non-gradable, it's better to take a good fundus photograph.
Yes. So if it's ungraded, see, the referral guidelines today suggests that if, as I told you, that if you have referable retinopathy, these are the terms as a postgraduate people will have. What is referable retinopathy? What is sight-threatening retinopathy? So sight-threatening and referable are same, which includes severe NPDR, PDR, DME. Okay.
Yes.
Moderate NPDR, again, if you look at various countries' screening guidelines, people shift it. Some people put moderate NPDR also as a referable retinopathy. So depending, but our Indian guidelines doesn't include them. So that's something you must know, that what is referable, what is non-referable or non-sight threatening retinopathy. No?
Yeah.
Yeah. In community screening will be adequate.
Everyone need to be clear about it. Especially as an ophthalmologist, we should know that which are the cases where you need to refer to a retina specialist.
Correct.
And sight threatening definitely means, by definition itself, all the lesions which are included in the sight threatening diabetic retinopathy are referable. That requires referral.
Yes. So in community screening, Dr. Soni wanted to know, in community screening, single field 45 degrees centered at fovea is perfectly fine. That is adequate for diabetic retinopathy screening.
In practicality, if you see, many of the people do not even look at the fundus.
Correct.
I want to highlight that 45 degrees is definitely adequate, but many people do not look into the fundus or the retina in diabetic patients.
Yes.
We need to propagate and educate every ophthalmologist also to look into. Of course, physicians and endocrinologists definitely require education. But many of the ophthalmologists in their busy schedules, they forget about screening the fundus, which need to be highlighted. In all diabetics, it need to be done.
I think the AI has helped the endocrinologist or diabetologist. Basically, they are taking these pictures, and with the AI, when they find some diabetic retinopathy changes, then they are referring to the ophthalmologist.
Absolutely correct.
Yeah, even for those people, it is much more. It makes it much more easy.
That's what I was telling. The ideal would be
for them.
Yes, ideal for a physician would be one AI system which grades retinopathy, and second, the retina risk algorithm, which I had mentioned, which gives the duration when he should come for a checkup again. If these two they have, we will be out of job.
No. I don't think.
No, not out of job. I'm just joking. I know.
No. That is the main thing. Actually, nowadays, not many are screening the retina.
I agree. I'm just joking. I know. Actually, our work will increase.
they will not get scared about screening the retina, and they will identify the sight-threatening retinopathy, and they will refer more cases actually.
Yes.
That is the contrary to the thinking that AI will make you out of job.
No. Our work will increase.
It will increase actually. Only good thing is that they will pick up at early stages and send. So we can do good laser and maybe postpone the sight threat. Loss of vision in these patients.
Yeah, I think for all postgraduates, I would suggest the the IGO article is sufficient, because diabetic retinopathy screening definitely can come in various forms in the exam. It's something which you need to read about it, and that article is sufficient enough to give more details. Majority of my talk was from there, except for that last AI part.
Yeah. Are there any questions?
Yes, sir. So I'm ready to ask you more questions.
Yeah, please.
So these are the questions that are from YouTube and Facebook and other portals. Sure. The first question is that is AI in India up and running, or are they still in the validation phase? And what are some of the commercially available AI programs in India?
So there are only few fundus cameras today available, which are there non-mydriatic. Forus is one of the brand, Bangalore based. It has got its own AI. You have Remedio, which has got its own AI. As I told you, Zeiss has got a platform called as Visual Health, that's again a AI platform, which is there. Selena, the Seri AI is inbuilt into it. So there are a couple of commercially available products which are there today.
There's another one which is called Artilus, which is quite good. The image quality and the AI part of regarding.
Yes. I'm eagerly waiting Artilus to come out with their OCT. Yeah. Because they are having a handled OCT. So I'm eagerly waiting. But Artilus, exactly what you said, is good.
And so are our programs FDA approved, the AI programs in India?
Many of them are not FDA approved. FDA approved, there are only two algorithms today, iNook and the one which I forgot, it's US based. Both are not available in India. Okay, but many of them are EU approved, European authority approved. Unfortunately, in India, we don't need these approvals, especially for AI, because still government is making these deep learning algorithms, AI algorithms, the rules. But today in India, you don't need approval to have these. EA approvals are enough. Majority of them are EA approved.
Okay, sir. And so how are the non-gradable images handled?
They need a referral. So like your sight-threatening retinopathy, which is a referable retinopathy, any image which is non-gradable should be referred. So they should be evaluated by an ophthalmologist. So it should be a dilated eye examination.
We suggested that if it is non-gradable image, take an image immediately, another image, so that it will be helpful. Otherwise, as Raju said, we will take it as sight-threatening diabetic retinopathy, so and it should, that patient
better to err on the side of evaluation.
Right, sir. So is it possible to customize the follow-up plans with AI?
Yeah, that's what I showed that there is, but though there are no products based on that, the deep learning based, but the only product which is available today, you can even Google and see the retina risk algorithm, and soon you'll be seeing the Indian version to it, which is available, where you can know the follow-ups. You feed in the data and it will say that how often you need to see this patient.
Right, sir.
There is one question from Meenal, Dr. Meenal.
Yeah, she has written a very good concern. Matter of concern, I guess, is a lot of rural population, not only rural, Meenal, it's even the urban population are not unaware. They're unaware of their diabetes status. That's what I showed, that 6% of the urban population, when they were diagnosed to have diabetes, they already had retinopathy. So that means they were not knowing their diabetes status. So that's a big challenge. And that's a big challenge. I agree with you. Forget retinopathy screening. What can be the solution for this? I think we need to understand that anybody more than 30 years in India is a potential diabetic, irrespective. So you have to just have regular checkups.
Suggest for a screening for diabetes. First of all,
Yes,
screening
yes.
for diabetes, and if they are proved, the very first instance itself, they should also get a retina evaluation.
Correct.
Okay, sir. So there's another question that what is your opinion on glaucoma screening with fundus photos, as it is controversial considering the definition of glaucoma requiring the HFA?
Absolutely. See, two things. One is, again, any glaucoma people here, not there. Two things. One thing I would say that glaucoma is not a public health problem. So WHO has defined which are the diseases which should be screened. And anything, no, prevalence should be more than 8 to 10%, then you think that this is a disease to be screened. So glaucoma doesn't, that's why you don't have this community-based glaucoma screening. So glaucoma screening should not, it's not recommended, that's one. Second, as you rightly said, the diagnosis of glaucoma is multi-instrument. It's not like just on a funder. You can just say glaucoma suspect probably on a retinal disc photograph. You need fields, you need IOPs, there are multiple things which are required.
Yeah.
So that's the reason I had mentioned the diagnosis of diabetes, and this is the only specialty, only disease in ophthalmology where the ophthalmologist has described also an entity called a suspect.
Yes.
You have glaucoma suspect. Can you have
Right.
diabetic retinopathy suspect? You can only have retinopathy or you don't have. Glaucoma is an entity where you also have a suspect. So it's difficult there. But yes, the second disease where AI is really going forward is glaucoma. Dr. Ronnie is working, and the multiple people who are working on multiple investigation and coming out with a AI thing to diagnose glaucoma.
Right, sir.
And,
So
Dr.
AI
Joshi
is
was saying that if retinopathy changes are detected, it's difficult to convince them. But Dr. Sohni, what we need to do is counseling here with their own fundus photographs.
Yes.
Should say these are the changes which are there, and if you are smart enough, keep 2-3 advanced diabetic retinopathy stages at the same time in the clinic, and tell them if you don't control or get treated at this stage, you can progress to the advanced stage, which can result in blindness.
Correct.
right, sir. Thank you for that, sir. So one more thing, artificial intelligence is a long question for many of the postgraduates, and surprisingly, it's a very often asked question these days, and directly comes as a long question. So, do you have any tips or the pointers for the postgraduates to mention?
BGO review article. I'm part of that. It's a beautiful article on AI in ophthalmology. Dr. Daniel Ting, me, and Dr. Pierce, the couple of group we all have written. It's a beautiful article on AI in ophthalmology, which talks about all possible things. I think 2 years back. Make notes of that for exam purpose, I'm telling, because that's something which definitely will come. And every day there are new applications which are coming. Like, see, AI, I always say it is useful for two things which we cannot see, predictive power, like I was telling people are using now, or make our work easy, like for screening. We don't have so many doctors, so it is used. So there are a lot of ways AI is used in ophthalmology today.
That's true, sir. So another question is that what is the minimum sensitivity and specificity that diabetic retinopathy screening program should
80%,
have?
80% sensitive and specific, both, more than 80%. You consider it as a tool for screening.
Right, sir. I think Sony has asked a question just now, that is, when do we detect them to be higher GRBS?
Already we have told.
Already taken.
Yeah, that's okay. Fine, sir. Right. It popped up on my screen now, so that's why I was just wondering that isn't it a repeated
I have
question?
a question for Dr. Rajiv.
Sure.
Right, sir.
Aniruddha,
So
yeah.
how accurate, or rather, what is the latest AI algorithms for detecting the macular edema? Because that is one thing which is very
He has
very
Yeah,
difficult.
that's what I was telling
he
you.
has
Read the
covered no in
ophthalmology
that.
retina. 2 days back, it is published ophthalmology retina article, where again we have trained a fundus photo using OCT
OCT as
grade.
well, yeah.
So I had
Both
shown some images
together
with,
it can help
so
more.
just seeing a fundus photo, it can tell whether it is center involving or non-center involving. The ground truth was taken from OCT, and that's pretty accurate, about 90% accurate.
I think that will be great, because most of the AIs are they detect the retinopathy part, but the maculopathy
Yes.
is
This
generally
is only for DME. This was for DME.
Yeah.
This
Not
was
only
across
that,
Shankar Nethralaya, LVP, not LVP, the Arvind and Thailand. Huge number of images were used here, and even from
yeah,
UK Biobank.
as the number of images increase, no, automatically the correction factors will add up
Yeah,
to the
so
algorithm, and then
we
it
found that
becomes
what is the limit. After that, the increase doesn't happen.
happen.
So for retinopathy, it is 60,000 images.
Right, sir. So how are the image trainers trained, and who trains them? Is like there a
Image
program or a
graders,
module?
image graders. Yeah, there
Yeah,
are
image
couple,
like readers, the ones who are
the
reading it.
ones who grade retinopathy or even
Correct,
fundus
perfect.
images. See, it's, as I told you, it's not necessary that you be an ophthalmologist. I have a team of some optometrists who do all the grading. You need to just make it sure there is consistency among them. So if they are wrong consistently, they should be wrong. I think that is what you need to ensure, though you don't want them to be wrong, but you make sure by a repeated test. So they do a test every month once on a set of some 50 images, and we try to maintain that they are on a good kappa between them. Yeah, but there are like, that's how a reading center is made. Dr. Rajiv Reddy has a nice reading center in LVP. So I think that's how, so you don't need to be an ophthalmologist. Anybody can grade retinopathy. If you teach them the lesions, you can do. And there's one of my article which came in Scientific Report, because there is no article which talks about on a single field which we use for screening, how you can grade retinopathy. So in that article, we had looked into the, rather than naming them as various lesions, we looked into yellow, white, and red lesions, and how you can grade whether it is referable and non-referable. So I think that's again something which you can use for retinopathy grading to learn.
And so what is your take on oculomics? I think this is something that the postgraduates should know, that it can be a new pop-up question after AI, and that is like the integration of AI and oculomics. So what's your take on that? I think recently Santosh sir had also put up an article on the same.
I'm sorry, I'm not very much aware about it. Oculomics, Santosh, can you answer that? What is oculomics, so that I probably am not getting the word? Santosh is here.
I'll just check once. Yes, sir, here.
Actually, just a composite term for biological markers. That's all.
Yeah. Okay.
Derived
Now I
from,
understood.
Proteomics is
from
there, I
various,
think.
various
Yes. So that's no. Nowadays there are so many new words. I thought there is
But
something.
yeah,
No,
yeah.
yes. What you are telling, the surrogate marker or biomarker for retinopathy,
But
and
this
can
is
that be used for screening? A very good question, and definitely for retinopathy, I am sure it will come. It's not, because there are a couple of biomarkers which are very much raised, and you will soon see in one of the article where we tried looking at 16 biomarkers, the blood-based biomarkers in retinopathy, and at 3 sites in India and 1 site in UK. And uniformly, there were 2 biomarkers which were raised for PDR. So I'm sure this type of, and this is coming in JAMA Ophthalmology next month. So you'll see that, and there are definitely definitive biomarkers for a sight-threatening disease. It's only that probably, no, like we identified one of them now, but there may be many which are there. So that's something future is based on these serum biomarker, even urinary biomarkers. No, so probably that's something the serum and these are the surrogate markers for retinopathy.
Right, sir. Santosh sir had recently, I guess, mentioned also in the article that it can be like it can cover all the neurological, psychiatric, cardiological, all disorders which are related. So biomarkers can have a good analysis, and I think postgraduates should focus on that, because adding that in one of the answers will help. And it is a possibility that suddenly oculomics appears and nobody will have an idea.
Yes, I agree with you. I agree with
because
you.
they love the new terms and trends.
New terms when we are using, that need to be defined also, because even in articles, what I'm seeing is some short forms are used very randomly according to the whims and fancies of the authors, which is not been moderated.
Correct.
It can create problem in future.
Yes.
Thank you so much, Rajiv sir. You have covered a very, very important topic, and you've covered it beautifully and elaborately. And I think, I don't think the postgraduates need to go anywhere, but as sir said that the article is mandatory, and the lecture, you can combine both of them and have a good answer, and make sure that you have it with you beforehand itself, because this is not a question you write like just a night before the exam. You should have it beforehand. So thanks a lot, sir, and thank you so much, Ajit Babu sir and Aniruddha sir, for being here. Anything you would like to say, sir?
No, last time you have announced some praises, I think.
Yes, sir. So I would like to share my screen.
Santosh
before
is there, yeah.
Yeah. So that's what I was asking, sir. If I have the permission, I have my screen to share.
Santosh,
just a second.
She's asking your permission. Postgraduates.
So these are the names of the hot seat participants who have been with us. These are 21 names. There are more actually, but for the first 21 to roll out in alphabetical order. And I'm glad that you all have been there, because it's not important for anybody else but you yourself. And like many of them messages constantly that these lectures are very helpful, and participating actively online helps a lot. So take tips from these people, because they have done so well, and many of them have joined their fellowships also now. And I'm proud to say that you guys have been a very good and important addition to the iFocus team. And the next session will be on March 4th. That will be hypertensive retinopathy by Dr. Aditya Kelkar. And hot seat participants, you will have your certificates in your inbox by tonight.
Great.
Thank you so much, everyone, for being here.
Thank you very much.
Thank you.
Rajiv, you have covered very well, actually.
Thank you. Thank you.
So much of this thing, and a wealth of knowledge in DR screening. I think you are the best.
Thank you, sir.
Satosh, good night.
Good night.
I think Lalit probably held up in traffic, I think.
He will catch up
He
anyway.
called me 10 minutes before 8, then immediately I rushed. Luckily, I was at home, so it became easy.
Sure, sir.
Thank you so much,
Thank you.
everyone,
Thank
for
you,
being there.
Good night.
Yeah.
Good night. Thank you very much.
Thank you.